I've been assigned to talk a little bit about defenses, resistance, acting out, and transference. These are a lot of different psychodynamic terms. Certainly there is some coherence to talking about all of them together, but I think, I'm sort of conceptualizing today as some time dedicated to building out your understanding of these different concepts. And I think, I enjoyed the conversation that we had last time. I know that I focused in on a couple cases that I had worked on, one in particular that I think I spoke at greater length about that I had as a resident, a psychodynamic patient that I worked with for a couple of years. I might bring him up again because there are a lot of examples that I learned from my treatment with him, and I had a great supervisor. I think you guys will find that when you have a great supervisor that you're working with on a patient, it's just a really outstanding learning experience, and they bring a lot into your understanding of how to manage some difficult situations, difficult patients, perhaps. But to recap a little bit about what we talked about last time, I think a lot of the work is in helping a patient understand relationships between their conscious thoughts and unconscious thoughts and behaviors. And I think both in terms of sort of thinking about it from a neural network standpoint, on the input and output side, there's a lot that is filtered both consciously and unconsciously on both ends of the spectrum, both with inputs and outputs. And I think that's helpful for understanding our work and the work of a therapist to help facilitate a patient's ability to navigate their lived environment a little bit better. In particular, I put this quote from Carl Rogers again on this introductory slide to sort of reorient us. And I really liked what he conveyed about his evolution as a therapist and the idea that our work is to form a relationship with this patient that we're working with in a psychodynamic context, and to use that relationship to further their individual growth. And of course, there are many different dimensions that we look at it from, this relationship from, and the challenges that the patient is experiencing, and many different ways that we go about problem solving. As I was talking about earlier with the different things that we're going to focus on, I think this quote came to mind for me. We don't talk about what we see what we know how to talk about. And I have no idea where I got this quote from, but if I were to put my money on something, it's probably from a TED Talk. Sounds like it would be. But I think what this idea speaks to is that as we build up a language of understanding, we'll be able to see more things that we were previously sort of oblivious to in our work as therapists. I wanted to start out by talking about a few domains of mental functioning. These are all sort of different mental models, and the next slide after this also goes a bit further into this. But when we talk about various psychodynamic constructs, you'll often hear some of these terms used repeatedly in different ways. So I just wanted to make clear a few different concepts. Firstly, what is referred to as the topographical model of the mind. Traditionally, it's separated into conscious and unconscious thoughts. There's a whole lot of more room for nuance. You'll hear or read about in psychodynamic literature, the idea of a preconscious in between. But really, what this focuses on is the idea that not all of what impacts a person's behavior and the way that they engage with their world is derived from conscious thought, and that a lot of it is under the surface in an unconscious way. And our work is to help recognize those patterns in which unconscious thoughts and behaviors impact conscious thought, conscious behavior, and help bring more of that to the surface so that more is within the awareness of the individual. The second is called the structural model of the mind. And this has to do with, there are various different structures, but the idea fundamentally is that mental life is not fleeting or erratic or sort of without an underlying architecture, but rather that an individual has consistent values, ideological understandings, a library of memories and representations of themselves and other people, amongst many other facets to the architecture of how their mind operates. And that this is a constant structure that helps us to understand an individual's cognitive processes. So one example for probably the early quintessential example is Freud's tripartite model, the idea of an id, an ego that mediates the boundary between id and superego. But certainly that is not the only one. I think last time I spoke a little bit about this guy Friston and his construction or concept of the free energy minima. That is certainly a little bit more on the edge of psychodynamic literature and conceptualization, but also fundamentally a structural model of the mind. And then subsequently, the idea of a motivational domain. This has a lot of, we could look at motivation from many different aspects, and I think during my training, that was the thing that seemed most present in terms of its relevance to therapy, but also the thing that we focused on least in terms of our understanding and how we approach it from a therapeutic standpoint. But I don't know, I hesitate to try to provide any overarching conceptualization of what motivation is, because there's a lot of depth and a lot of different angles to look at this problem from. But I would just sort of be aware that motivation is a key domain from which we look at cognitive function. And then developmental models of the mind are, I think, another important aspect that certainly have a huge role in psychodynamic formulation of patients. And this has been referred to as the genetic perspective, and I put that in quotes. Genetic in this psychoanalytic terminology has nothing to do with DNA, but rather the idea of genesis, or the story of origins. And so oftentimes a person's understanding of who they are is heavily impacted by their understanding of a sort of developmental narrative of what they've experienced in their life. And the work in psychotherapy can often be to look at disjointed developmental aspects or parts of their developmental history, and help the patient really develop a more cogent and coherent narrative about how their developmental history relates to where they are today, and how they approach. I think you could argue that it links into the structural model, how they approach their values, principles, ideologies, and other aspects through that developmental lens. And so some of the content that I took from this, that's in this slide, I pulled really from this book that I had. I think it's a worthwhile book to take a look at. I don't know if you guys have seen it before. The Psychoanalytic Model of the Mind. But it was written by Betsy Auchincloss. She was the assistant PD where I was in residency. And a lot of the, as I was saying, things that I pulled into this slide and the following slide are taken from the intro in this book. But I found it helpful to sort of use that as an orientation. So in addition to the topographic and structural models of the mind, Betsy, in her book, goes on to talk a little bit more about object relations theory and self-psychology as two other fundamental models of the mind. Object relations is, in concept, a model that focuses on how somebody develops a conceptual understanding of who they are as individuals, and an understanding of who the other is, and the linked interaction between the two. This is, in particular, I think, very relevant to um, borderline personality disorder. I mean, it's relevant throughout work as in a psychodynamic modality, but you'll find that a huge part of the challenge with patients who suffer from borderline personality disorder are that they have a really impaired understanding of who they are as individuals, and also a very, on average, impoverished ability to conceptualize other people with any degree of nuance or granularity. And so that's where the sort of like the splitting and black and white thinking come in, and understanding of the motivations of others. And then the last model of the mind to make note of is that of self-psychology. And to me, the not terribly unrelated from object relations theory, this is a focus on understanding the functional, the functioning of a basic structure called the self, and how somebody develops a clear and coherent understanding of who they are and what makes them themselves as an individual. So with that as a little bit of a background and a little bit of an orientation, I wanted to turn a little bit to some of the other tasks that we have been assigned to discuss today. So the first that I wanted to focus on are defenses and resistance. And I thought that this quote I pulled directly from Dr. Swintak's slides that perhaps some of you may have seen last year. But I thought that this was a hugely important quote that really helps us understand defenses and what role they have in our life. So Deborah Cabanas, I don't know if that's the correct pronunciation of her name or not, but she's at Columbia and works as a psychoanalyst. She wrote that defenses function the way our sense of balance operates when we want to keep ourselves upright on the deck of a boat, automatically and continuously making tiny adjustments without our awareness. Just as our balance system automatically senses the tiny movements of the boat and deploys muscle movements to keep us upright, our mind senses tiny changes in our anxiety and emotional tone and deploys defenses to keep us functioning on an even keel. When I read that, to me, it was really profound and profoundly helpful for understanding why we focus on this idea of defenses, right? Like even going back as early as all of our experience in med school, one of the things that we've had to study for our STEP exam were primitive defenses, mature defenses, being able to label them, being able to distinguish what's primitive from mature. And I think that, at the time, it really didn't drive home to me why we differentiate these two. I certainly could appreciate the difference between what seemed to be a sort of elementary or primitive defense versus what was mature, but I don't know, what are your thoughts? And when you think about mature defenses versus ones that are a bit more rudimentary or primitive, why do you think is there importance to the distinction, and how does it come into play as the work that we might do as a therapist?
My first thought is the more immature defenses might cause more distress in someone's life because it's maybe causes more, what do they call it? I don't know, more strain in interpersonal interactions, like the acting out maybe.
Absolutely, absolutely. I think that's completely correct, Whitney. So there are a few different layers to the challenge with defenses, and I think what you touched on is exactly right, in that more adaptive defenses preserve or enhance function, and less adaptive defenses, more often than not, tend to hinder function. But the important thing to recognize as well when we think about this is that a person deploys a defense strategy, whether it's element primitive or mature or however you want to frame it, in a way that's to the best of their ability, and often when they develop certain patterns of defense, it's because they've gotten positive feedback in the sense that it has been helpful or adaptive to a particular situation that they've encountered or sets of situations. And so I think this is particularly relevant also to our understanding of personality disorders, that generally, as with other forms of pathology throughout medicine, what starts out as an adaptive response, when it continues to progress and be applied to other situations, right? So let's take the example of heart failure. Initially, the response of hypertrophy is adaptive, but over time it becomes dysfunctional in heart failure. And for personality disorders, what may start out as adaptive can in fact become highly, highly maladaptive when they rigidly apply it to other situations. Something that helped me a lot understand personality disorders was something that one of the teachers I had said. He said, if you look down the list of personality disorders and you read the description of each one and you think, oh shit, I've got all of them, then it means you have none of them. And what he meant, of course, was that we all successfully deploy narcissistic defenses, antisocial defenses, avoidant, whatever, what have you. But the problem really comes when you really just sort of have one note to play, and when no matter the situation, you use the same rigid response, and that's when it becomes problematic. So, I thought it was another attending of mine pointed out that when we walk into a patient's room for the first time as a medical student or as an intern, we have to really be quite adept at deploying some pretty antisocial strategies to convince them that we are trustworthy, that we know what we're doing. But in the context of that situation, it's really important that we do that. It's important for our own learning. It's important for the patient to feel comfortable with the care that they're getting. And so, the point I'm trying to drive home is that rigidity really defines what is helpful versus unhelpful. I think to speak a little bit more about mechanisms of defense, the function that they serve is to really sort of decrease awareness of painful feelings, or to avoid situations where the patient is confronted by painful or otherwise negative cognitive experiences. And so, this slide is again adapted from Dr. Swintak. She provided the example that splitting can handle strong opposing feelings of the cost of being able to have splitting to handle, what did she write actually? So her example is splitting to handle strong opposing feelings of the cost of being able to have meaningful relationships. I guess she meant to write at the cost of being able to have meaningful relationships. Or dissociating to escape overwhelmingly bad feelings at the expense of being able to connect to reality. So I think what she's getting at is that even with a primitive defense such as splitting, that it can be helpful when we have overwhelmingly negative feelings about somebody that we need to interact with to get along in our day-to-day life, that it can be useful to split off those opposing feelings. So to bring it back to the patient that I had a lot of experience with, that I spoke about earlier, when I was in residency, I treated an 80-year-old gentleman who had sort of lifelong homosexual desires, but had never really felt comfortable acting on that or living his life as a gay man. And he lived, hopefully he's still alive, he has lived his life for the past like 55 years, married to a woman whom he has never had sex with, who they don't have any sort of sexual relationship with. But for him to function in a manner that was functional in the environment that he grew up in and the environment that he wanted to live his adult life in, he had to very much sort of split off that an ability to integrate his homosexual identity or his desires to live life as a gay man. And for him, that was sort of the way that he was best able to figure out how to live some semblance of a functional life, although of course it came out at an extraordinary cost. I'm going to skip over this example. I'm not sure if it's going to further the conversation for us. I think we sort of talked about some cases already. But to sort of recap an overview of the defenses that we talked about already, the work is really to help minimize the conflict that somebody experiences through their deployment of defenses. And they often operate outside the realm of conscious understanding. And so again, this goes back to the point that our work in part is to help the individual become aware of the situations in which they're deploying defenses so that they can begin to understand sort of from a cost-benefit analysis standpoint, the relative cost of the types of defenses that they're deploying and what they're really pushing away from their own awareness when they're activating some of those defenses. In turn, the goal becomes to reduce cognitive tension or discomfort and maintain an intrapsychic equilibrium, we might say. And for the next topic that we're going to talk about, acting out is one way that within the therapeutic context that patients begin to express some things that are difficult to articulate in verbal terms in the therapy itself. And so it may point to an expression of intrapsychic conflict or painful emotions through overt behavior, expression of unacceptable thoughts or feelings in their actions, and the discharge of conflicted mental content by means of action rather than by means of verbalization. So what does that mean in practice? I think that there are many ways that a patient can come into therapy and, although not be able to communicate certain patterns of behavior or communicate conflict or challenges that they're having, in the therapeutic context, there are many ways that it sort of comes into the room. Let me give some examples of ways that it was relevant for me with the work that I did with the patient that I was talking about earlier. So oftentimes with this one particular patient, the 80-year-old gentleman that I've been talking about, he would be, as I'm sure you guys have experienced in residency, you have number of back-to-back appointments. Sometimes you run a couple minutes late. Sometimes you have a little bit of space and you're a couple minutes early. There was a profound rigidity that I experienced in my 2 years working with this guy. And precisely at the moment that the clock struck, let's say, I forget what time I saw him, it was like maybe 1:30, I would hear a knock at my door. Didn't matter whether I had a patient in there or what, I would always get a knock at my door at exactly this time. And he would not be, and when he would come into the session, he would always sort of say, almost pretend like he wasn't aware of what time it was, or sort of act casually that, it's okay for us to get started a few minutes late. But what he was not able to talk about is that, there was an expected boundary to our relationship, that my time was dedicated to him from 1:30 to 2:45 or 2:30 rather. and that he had a certain expectation that I was going to see him because I had a certain responsibility to him. And it's sort of, this will get into another concept a little bit later, but this sort of had to do with his transference response to me and him seeing me as in sort of a father figure type role, amongst other various roles. So as we spoke about last time, there are sort of various layers to the meaning and the transference that a patient brings into the room. But fundamentally, his focus on when the session got started was rooted in an aggression that he couldn't really articulate and couldn't really engage with in any direct means. It's helpful to be able to interpret those situations when you build up a relationship with somebody, when you build a relationship with a patient. But it takes a little bit of time and establishing a therapeutic alliance to begin to enter into a space where you can provide an interpretation and hopefully begin to open up a space for them to talk a little bit about some of their the ways in which they are engaging with you in the treatment. Another.
How does that come up? I'm sorry. I mean, how does that? I mean, I'm guessing you wait for it to organically come up, or how do you?
Yeah, I think I'm particularly hesitant to, I think one of my challenges in residency and probably ongoing is that I'm more hesitant to make an interpretation and seem like I'm, reading too much into a situation. And I think, it's a delicate balance to figure that out. But, oftentimes I would wait too long. That's something that my supervisor would tell me about. But when a patient sort of says something to sort of dismiss or almost demonstrate a sort of reaction formation response, it's a good opportunity to hold with that line of conversation. So oftentimes, a patient will say, "Oh, it's not a big deal, but I don't know. I'm trying to think of an arbitrary example. The patient might say, "Oh, you must have been really busy today." I don't worry about it. I totally understand. You don't even need to apologize. You don't need to. It's quite all right. Rest assured, it's quite all right that we started late today. What the patient is doing is more attempting to repress or institute a almost reaction formation like response to their uncomfortable feelings that they may be having about how you may have betrayed what they expect from you in terms of starting on time, having a clear and understandable and comprehensible boundary to the relationship. With this one particular patient, there was one time when I think he got so frustrated with the fact that, I was pretty lax with like the first 5 minutes of when we would start relative to what he was expecting. So, we would start anywhere between 1:30 to 1:35. And after I was on vacation for like 2 weeks, and I remember him coming in the next session and saying something effective, "So what's going on with you?" And, open-ended, but it's sort of like a little bit overtly hostile. That's how it felt at the time. I had no idea what he was talking about. I had actually gotten married and was returned from a honeymoon, so I thought maybe I looked different. I looked tanner. I thought maybe that's what he was referring to, but I had no idea what direction he was going. So I sort of opened up with some open-ended questions, just allowed him the space to talk further about what he meant. And it turned out, I think that in my recollection of what we were talking about, it had also to do with what time we ended the conversation, what time we ended the therapeutic session, because oftentimes, and this gets into acting out as well. One of the other strategies that he would deploy with me, especially in the first year that I worked with him, is tremendously frustrating because he'd use a sort of filibuster method. So oftentimes I would ask probing questions, and he would very quickly meander off into something just sort of totally irrelevant. He was fond of going into the gritty details of a baking recipe, and it would just sort of overwhelm me and exhaust me. That, you know, it takes effort to constantly refocus a patient, and after weekly sessions for several months, it begins to frustrate you when the patient continues to filibuster and try to ignore some of the redirection, refocusing on more introspective material. And so one time in response to this, I think the immediate session before that, I remember thinking, you know, he's going to run out the clock on me again today. And so I was like, you know what, be damned, we're going to sit here until I feel like we're done. And so he, in very typical fashion, had sort of filibustered throughout the session. And then within the last 5 minutes began to speak a little bit more directly about a gay relationship that he had, not a overtly sexual relationship, but there was very clear homosexual undertones to it. And so this was really important material for what he ostensibly came into the treatment for, or to discuss, or to, begin to understand a little bit better. But he was planning to run out the clock on that, and sort of at once I'd say sort of tease me with relevant material to keep me engaged enough for next time, which in and of itself, I would say has some sexual undertones to it. But I sort of refused to engage with that, and indirectly forced him to continue to talk about it by running over time by 15 or 20 minutes. And so that was one situation where I know we're going into a lot of gritty detail about the frame of the session, but it is helpful when the patient brings up some sort of distress about it to ask open-ended questions. And my advice through my own failures is to not allow them to escape, if at all possible. You don't have to be overly domineering, but be persistent with the questioning. And oftentimes patients will sort of gloss over their responses and try to say things that are socially acceptable or comforting. But I think asking further probing questions to begin to help them feel more comfortable talking about conflicted emotions can be helpful. So I think, in essence, not leaving the topic of conversation and demonstrating that you're comfortable talking about it, and that it's okay to talk about the interpersonal relationship that's manifesting in treatment, and that relationship in and of itself is something worth talking about directly, is actually really important. Are there any patients that come to mind for you, Whitney, where something similar might have happened or a similar challenge might have come up?
Specifically about the countertransference, I'm not thinking of a specific example. I assume that it's there based off of my countertransference. I have one patient who is very grandmotherly-like, and one of the reasons why she's in therapy is relating to isolation, feeling isolated. And so I can't remember an instance where I felt like I could speak to what it seems obvious to me in regards to those dynamics. So that's what my question was about. Like, you know, was that something I should have brought up a long time ago, or you just kind of wait until it organically brings itself up, or, you know, how do you approach that? Because it's I think it would be helpful. It sounds like it would be helpful to really explore and
Yeah. I think one thing, you make a great point, and one thing that I'm hearing in that, or one thing I'm sort of internally responding to, is when is the right time to bring up something, and you know, how much evidence do you need to wait for, or what becomes the opportune time. I think pointing out patterns that you recognize and just seeing what the patient does with it is great. And you're going to get all sorts of responses depending on sort of how psychologically minded the patient is. And some people will really be able to work with it, generally the higher functioning individuals that you work with. Some folks won't get it, but I think it's important not to be deterred. One thing that is really important from a process standpoint in psychodynamic work is that you're not going to make an impact the first 2 or 3 times that you bring up something. And that a lot of the work is allowing patterns of behavior to unfold and to point it out to the patient. And, you know, honestly, it may sound a bit absurd, but if you have a measure of trust in me, sometimes the 7th or 8th time that you bring something up, the patient will begin to listen a little bit more intently and will be able to form their own connections or understanding of what you're trying to get at. And then they may sort of revise their own understanding of all those times that you pointed out, you know, whatever it was to them previously. So, you know, perhaps the first 4 or 5 times that I talk with this patient that I had about the frame of the treatment and what it means to start on time, what it means to finish on time, it may not even be like a coherent understanding that he has about why it's significant to him, but there may be something that comes up in treatment later that allows him to recontextualize why he is having an intense emotional response to this concern with the frame of treatment and the expectations of what timing means and what he has, what I owe him and what he is expecting out of me. And to sort of, you know, really bring it full circle and drive home the point, I had an ongoing conversation with this patient about a paternity leave that I took during my treatment with him. And so I disclosed that I was having a paternity leave. You know, last time I had mentioned that because of his own transference and how he conceptualized me, he had a fantasy that I was adopting a child, et cetera, et cetera. But once I told him that I was going on leave, he had an extremely emotional response. And I wasn't in a position, you know, I'll get into this a little bit later, but for my own countertransference, I sort of refused to believe that I had such a large role in this guy's life. And it took me a while to come around to the understanding that he had an intense emotional response to the idea that I was sort of abandoning him in a sort of parent-child dynamic, right? So like for him, this new child that I was having was competition for his attention, and that I was shirking my responsibilities to him by taking a leave of absence, which then also, you know, telescopes into how he conceptualizes my responsibility and my attention to him in terms of when I start the session, when I end the session as well. But you know, that might be one way to begin to look at some of those factors. So a couple other things to talk a little bit further about. Resistance, and there's, I think there's an overlap or an interface between some of the concepts of defense mechanisms, acting out, resistance. But, I would describe resistance as a patient's unwillingness to change and grow within therapy. And just as I was talking about earlier, the filibustering strategy is one form of resistance that a patient may come into treatment with a clearly stated reason for why they are there, but it may not be actually congruent with really why they are coming to treatment in actuality, and that there may be a consciously stated or superficial reason, and there may be an unconscious or more deeply seated issue that is covered by the superficial reason. And so repetitive material or filibustering is one way that a patient may do that. And it takes some repeated work, again, and some tenacity to point out when a patient may be filibustering. Depending on who the patient is, depending on my relationship with them, I may be hesitant to use that term or call it that. But I might, when I ask a question, often what I did with this patient that we've been talking about is when he would begin filibustering, I would begin to sort of interject progressively more immediately and say, how do we get to, I lost track of how we got to talking about baking when I had just asked you about this. Or I may interject to say, do you remember the question that I asked you a minute ago? And then, they may or may not respond affirmatively, or they may not remember the question. And then, it's an opportunity to continue to probe, well, how do we arrive on this topic of conversation? What's the relationship? And there's more depth to go into there. Depending on the patient, they may also engage with other forms of resistance, like silence and giving you minimal information, or a minimal ability to, it may feel like sort of, in like tennis or some racket sport, that you serve them and they just can't hit the ball back. Or if you're, playing catch with them, that you're continuously trying to throw them something to work with and they're just not able to give you anything back. That can be another very prominent form of resistance that takes a bit of time and a little bit of gentle persistence to work through. And then, as with this patient, although he certainly did not have lateness, I think the concept of the frame of the treatment from a logistical and time standpoint had a lot to do with the work that we endeavored to focus on in therapy, and what also was not consciously discussed, at least initially, with him. So to elaborate on this a little bit further, I think this also goes back to Whitney's excellent point of when to address when to offer an interpretation, and how to offer an interpretation. It takes a little bit of experimentation to figure out what the right balance is between going too deep versus being so superficial that it's not really useful to the patient. And based on what, again, this slide is adapted from Dr. Swintek, but she articulated this idea of going just below the surface so that it's not so deep that it's beyond the patient's ability to draw a connection or understand, and not so superficial that it's of little purpose or literal value to the patient. There's no easy way to describe where this point resides, but I would encourage everyone to really think of the early part of your career as a huge opportunity to just experiment with this work, and that there's relatively no risk to getting it wrong, that you can always recover in a longitudinal relationship with somebody, with the patient that you're working with. And it may provide just, as we call it, more grist for the mill, more stuff to work on and develop your therapeutic relationship with somebody if they respond poorly to a deeper interpretation, or if they respond dismissively to a superficial interpretation. So do some experimentation with what that feels like in your own psychodynamic work with patients, and you won't be disappointed, because that's really what's going to carry you forward as a clinician, is doing that work to take some, well thought through risks, but ultimately to take some risks with how you're engaging with patients and trying different approaches. Here's a case that maybe we can spend a few minutes talking about. A 29-year-old female with borderline personality disorder who was sent to live with her aunt when her younger brother was born, told her therapist that she was, quote, pleased to have a break from treatment when he told her that he had canceled a session. Her mood changed from one of generalized anxiety and depression to overt happiness accompanied by curt comments. On the day in question, she came expecting her session, and when she realized that her therapist was absent, she became acutely anxious, feeling that her existence was meaningless. She was admitted to the hospital with suicidal ideation, complaining that her therapist had discarded her because he, quote, preferred to see his family, end quote. Yeah, I'll just sort of sit back. What are some of the things that you notice and what's going on with the dynamic here?
It seems like some abandonment issues.
Yeah, absolutely. What do you make of the, it seems like a bit of I'm sort of feeling some vacillation between how the patient is responding, that at first she is pleased to take a break, and there is some sense of relief perhaps, and then later she is sort of acutely confronted with something that intensely swings her emotions to into a very different direction.
I think when she said pleased to have a break from treatment, that could have been a reaction formation.
Yeah.
I'm not even sure if this is occurring, but I'm wondering how she went from being completely okay with it to then coming in. Like, was there some dissociation that happened? I don't know. It's very bizarre how she came in expecting the session. I don't think it was one of being forgetful.
Yeah, absolutely. I think your point is something that is really, really valuable. I was surprised to see in my work and my handful of years as a clinician how often things like this tend to come up. My guess is that in this particular situation that there is a degree of unconscious denial to the point that the patient is not able to cognitively recognize or process information that is an affront to her ability to function. And so, I remember one of my other supervisors talking about a patient who was not able to see, I forget the details, but kind of in a similar situation. The patient was talking about marital relationships and had similarly sort of placed on the therapist a fantasy that she was an unmarried woman without children, and there's sort of a maybe projective identification type approach that the patient wanted to feel like the therapist had a very similar structured life to her, that she was unmarried, didn't have children, middle-aged, approaching menopause, and could not see the fact that the therapist wore a wedding ring. But then when the therapist sort of addressed it in the therapy session, when the patient sort of talked about this idea of who she thought the therapist was, the patient actually sort of got annoyed and angry because she insisted that the therapist had never worn the wedding ring before, and that this session was the very first one that she was wearing a wedding ring, and that she thought that the therapist was trying to either lie to her or didn't remember, didn't understand. But that was a real situation that one of my supervisors talked about working through with the patient. And it sounded sort of far-fetched to me when I encountered it. But I feel like I sort of also experienced some degree of that when I sort of more and more directly spoke about my paternity leave and having to go on leave for that explicit reason with the patient that I had. And he could not engage with the idea that I was having a child because of having a wife who was pregnant. And so the evidence I brought to the table with him was progressively a little bit more direct in how I approached it, but no matter how direct I became, it did not cognitively process it. And it's a really interesting, it sort of changed my perspective on defense mechanisms and psychodynamic work because of that. I would suggest that perhaps, as you're pointing out, something vaguely similar is going on with this patient, that she may be not in a position where she can cognitively process the canceled session. And so it has been pushed out of her awareness, and then she may have legitimately, I don't know whether that's the right term, but we'll say forgotten about the session, then shows up for something that was canceled that she was previously aware of, we'll say. So yeah, I think that is also a big part of what's going on in this picture here. And then I think it's also interesting about her explanation as well, that there is sort of there's a clear relational dynamic as well, right? So there's a preference between the patient and his family, and she is suggesting that he prefers his family. And what I'm reading into this is that she is one of the transference reactions is that of a child with a parent or a daughter-father relationship type dynamic that she is embedding in the treatment, and that she is pushing onto the therapist the idea that he is abandoning one of his children in favor of others, or in favor of whoever constitutes his family. But I think there are a handful of different vectors through which to interpret what's going on with her emotional response. And I think all of those that we talked about would be helpful to begin to bring from her unconscious attention to her conscious attention, and to perhaps speak a little bit about further with her. And we go back one slide. Sorry, my slides are mixed up. Yeah, so let's talk a little bit more. The last topic that we'll cover today is the concept of transference and countertransference. I think these are concepts that you've already begun to address and understand. I would just add to the conversation that it's important to recognize that transference responses from a patient are not just one-dimensional, that there are often different layers to the transference, and that there are multiple relationship dynamics that will sort of come to the fore at different times. So as a therapist working with this patient that I've been talking about, there was an element to the transference where he a sort of parental transference, we might say, where he looked to me in a father figure type role. There was also definitely an erotic transference that he had, that he had difficulty being able to address directly in the treatment. And then there was also a simultaneous hatred. So one of the things that this patient I spoke a lot about was that he had a sort of strong, almost compulsive desire to watch gay strangulation porn. And he was really turned on by the idea of the fantasy of strangling naked, muscular men. And it was, and his wife sort of mandated him to treatment after the fourth or fifth time that she had observed him or caught him watching this. And, you know, I think that hatred and animosity was for this particular patient a fantasy that closely related to how he perceived his father. And it also entered into how he interacted with me. So in some ways, you know, pushing me out of the room or preventing me from interacting with him, or having a voice in the therapy in the ways that he would filibuster, is metaphorically not terribly dissimilar from choking somebody, or wrestling them, or, you know, whatever. And so I think there are these multiple layers to the ways in which he engaged with me as his therapist. And I would articulate that looking for these different vectors to how a patient is interacting with you, and when a particular relational dynamic comes to the forefront in particular situations, is useful to begin to focus on and understand more closely. You know, oftentimes we focus on the idea of a positive or negative transference as being useful. I think it's also important to go a bit beyond just these positive and negative connotations and look for particular relational dynamics. So it will be helpful in your work to, when you notice that you're beginning to think about a positive transference or a negative transference, use that as a reflex to prompt yourself to go a bit further and ask yourself, well, how can I describe the transference dynamic that's occurring here? What are the relational components that this patient is enacting? And I'm going to skip ahead a little bit here. This also directly relates to countertransference, or how we respond to a patient. And I wanted to talk a little bit about the concept of technical neutrality. So this term is used often in therapy work. Something that's important to understand is technical neutrality is different than that concept that we spoke about last time of sort of being a blank slate. That technical neutrality just really refers to as technique, and it's not technical in the sense of mechanical. What it really refers to is the idea that your countertransference can help facilitate the patient's understanding by either being consonant or complementary, and to help facilitate an understanding and a sort of mentalization of what is going on and how the patient is viewing a particular situation, by facilitating from a neutral standpoint the patient's ability to look at multiple different perspectives in a situation that may be causing them distress or may be perplexing the patient. And in contrast to technical neutrality, I wanted to offer the idea that Carl Rogers had, which was he suggested, I have some qualms with this idea. I think there's a little bit more room for debate, but I just offer that Carl Rogers suggested having an unconditional positive regard for the patient, and that you can have a unconditional positive sentiment, but that doesn't necessarily conflict with the idea of technical neutrality, that you're offering different viewpoints to the patient to help facilitate a more multi-dimensional perspective for them to begin to comprehend and think about. And then I just wanted to, almost as a footnote, sometimes people will use the term acting in. This has various meanings depending on what type of literature you're looking at, but the most common usage that I'm familiar with is in the psychoanalytic jargon. And it means the countertransference that a therapist brings into the treatment. And so when you have a patient that maybe reminds you of a particular mode of interacting that a family member of yours has, or something that begins to pull your own personal experiences and has emotional weight to it, that can really affect how we interact with that patient. And more often than not, it creates a distancing if we have uncomfortable emotional responses to patients. But it is very important to be aware of that tendency. And that awareness can also help us to gain perspective and understanding of the ways in which we might be enacting our own defense mechanisms, which very much can come into play, in particular with challenging patients. But you may see the term acting in. I just wanted to make sure that you guys had an understanding of what that might refer to if you see that in the literature, especially as we're talking about its converse of acting out. Do we have, are we about it for time right now?
Yeah, I think 3:30 was our end time.
All right, so we will close for today unless anybody has some burning last minute questions. All right, well, thanks for giving me the time today to chat a little bit about some of these concepts, and hope you guys have a good rest of the week, and we'll look forward to seeing you around.